It's our last chapter. So let's talk about therapy. As a clinical psychologist, I do a fair amount of therapy. I have a practice. I have been doing therapy ever since or actually while I was in graduate school, I started learning about how to do therapy, and I've been doing therapy pretty much ever since then. And so over 20 years worth of experience in doing therapy, and I'm happy to share some fun information that will, I think, expand your view beyond what is just in the chapter for this area. Okay, so let's talk about therapy. Questions that you might have about therapy would be things like, does it even work? Yeah, and the answer is yes, therapy works. Overall, there's great evidence that supports therapy working. Then we'll talk about some more of that in a minute, like, does it work for everyone? Does every therapist work? It's not quite that cut and dry. How much therapy do you need? This is a question that lots of people ask me. I do a free initial consultation, and so people can come in and chat about what they're looking for, and then I can keep an eye on them and kind of think, am I really the best person for them? Are they a client that I want? Are they a client that I think it's just not a good match for me, or I don't really do what they're looking for? And so that really helps. But a lot of people want to know, how much therapy do you think I'm going to need? And it's hard to tell. You can't really tell the first session. It takes a few sessions to figure out how much do I think you'll need. Some of it depends on what you're dealing with, and some of it depends on how hard the client is willing to work and how much they want to change. And so I operate on a model of self-pay where I don't participate with insurance companies. And what I find is that when people are paying for their own therapy, they work pretty hard because they're really interested in stopping as soon as they get relief. And that model seems to work pretty well for me, at least. And so I don't really know how much you need, and not really for at least a few sessions. Once in a while, if it's something that's really simple, then I could say, I think that it would take X amount of time. And then it's usually something that is perhaps 8 weeks, maybe 12 weeks, something along those lines. Sometimes I'll say, well, I'm not really sure, but let's plan on 10 weeks. And then after 10 weeks, we'll reassess and see where you are. That also works for some people. Sometimes people need sessions right in a row, like every week for a month, and then they sort of have it down, and then we can back off a little bit. Sometimes they need every week for years. I've had some clients with really severe troubles that have benefited from several years in therapy, and then they're good. They're great. They go off and they're finished. So it's very much individual, and it's not all about what the problem is. There's a whole host of factors that interact there. How long should a session be? Well, again, that kind of varies. And one of the things I love about being independent in my practice, in other words, not being tied to a managed care plan or to insurance, is I can make the decision on what my client needs right then based on what I'm seeing. And so there have been times where I've had clients who really need a longer than 1 hour session, and they benefit from longer than 1 hour. I have clients who need I generally do a 45-minute session. And then I've got some times where a client just needs to kind of report on the things that they're doing. And so I say, okay, well, that sounds like what you're doing is exactly what I wanted to see. I needed you to check in, but we don't need more than 15 minutes. And so they don't pay the full price. They just pay like a 15-minute section, whatever. I'm trying to think of what that means. Anyway, they don't pay the full thing. They pay a prorated amount for however many minutes we use. And so it's nice to have that model where I can adapt it to what the client needs in the moment, and I could really work from the client's best interest. And I have to say that it is That is a really important thing to take into account, is that if you're working for the client's best interest, much of the time you're working against your own financial interest. And that has to be something that you're okay with as a therapist, that you're not so desperate and crazy attached to how much money am I going to make that you have a hard time seeing that today the best thing for this client is 15 minutes and not an hour. And yeah, so I'll make less money. But what I'm interested in is that client getting better and doing what is best for that client. So you have to be able to have that model in mind and really be committed to it. So how long a session should be? My standard session, most people's standard session is 45 to 50 minutes. And that generally works, but there are sometimes some people and some situations that require longer or shorter. All right. What kind of therapist is best? We're going to answer that in a little bit. Is therapy awful? Of course, from my perspective, I don't think it's awful. I think it's great. But a lot of times people have this misconception that they're going to go to therapy and they're going to have to unearth all of the things that they never, ever wanted to see again. And maybe some therapists require that. I think that they shouldn't. I think there's no evidence that shows that that's actually useful. The kind of therapy one of the kinds of therapy that I do a lot is therapy for people with trauma. And you would think if people are going to be unearthing difficult stuff, it would be in trauma therapy. And one of the things I tell them is, we don't do that. That's actually not useful. We don't go looking and digging up, and now you have to rehearse to me all of the time something happened to you. We actually know that that is not very useful. And so you don't have to worry about that, it being awful in that particular way. And then I have a lot of clients, actually, it's hilarious to me how many people have come up to me and they've said, well, not come up to me, but in session, they'll say, am I the worst client you've ever had? I probably am the worst client you've ever had. I'm like, no, you're not. It is really hard to freak me out. I think I've heard pretty much everything. And I don't know about all therapists. I think I have pretty decent boundaries in terms of what is upsetting to me and what is not upsetting to me. For the most part, I leave therapy in the office. I don't bring it home with me. And so I don't have nightmares about my clients. They're pretty much grown-ups, or they're in great shape. They can take care of themselves, or they have to learn how to take care of themselves. If I'm going to be their mommy, that's not a therapeutic relationship. That's not a helpful relationship at all. I can't be people's mommies. And so in that way, I don't bring them home with me almost all of the time. There have been maybe 2 or 3 exceptions over the last 20 years where I've been really bothered outside of therapy. And so the other thing to think about is I don't remember very much of what happens in therapy. And so if I run into a client a few years later, like say we're in the grocery store or something, and I run into them, I am not thinking about all the things they said in session. I probably don't even remember any of well, I might remember like what their basic issue was, but I don't remember very much. Even the clients that have had really difficult problems, or that I had a long-standing relationship for some time before we ended therapy, I still don't retain all of that because I'm not reviewing it. It's not like it's not a thing for me to review it. They got better, great. I'll probably remember how much I liked them. That I'll probably remember. But there's no like I'm walking around with lists of what people have said to me in the past. For I would say probably 99% of the things people have said. When it's no longer relevant, I don't remember it. Well, so maybe that will help in terms of questions about therapy. So let's jump in. There is this thing called the dodo bird verdict. And so the idea, this is really taken from Alice in Wonderland, this idea of all have won and therefore all must have prizes. So the idea here is that we looked and looked at different kinds of therapy versus other kinds of therapy. And what we found is pretty much they all work. So all have won, all must have prizes. The idea is that in general, psychotherapy works. I'm not talking about weird psychotherapies. Like, I wouldn't recommend primal scream therapy to anyone, but in general, regular, normal psychotherapy works. It does seem that the specific type of therapy that you do doesn't really seem to matter. And so if you're like, oh, well, I should go do cognitive behavioral therapy because that has the most empirical support. Yes, that is true. It has the most empirical support because it's the easiest to study, not because it's the best. It's just really much easier to study because you can manualize cognitive behavioral therapy much more easily. Manualize means that you kind of follow a structure and then you just kind of do what the structure says. You follow the manual, the client follows the manual, and everything just works out beautifully. Not really, but that's the idea, is here's this manual, go through it. Did the person get better? Well, yes, they usually do get better, and it's really easy to run that kind of a study. If you have a study using other types of therapy, you can't really manualize them as much because they're more individualized. Now, if you want a great example of a manualized therapy that is great, that works really well, you can look on Amazon. Under there's a name called Treatments That Work. That's sort of a series, a workbook series, Treatments That Work. And so, for example, they have a treatment for OCD, or a treatment for trauma, or a treatment for anxiety and panic disorder, that sort of thing. And those are really great treatments. They're all manualized, but they're really good. So the client can buy the client workbook, the therapist can buy the therapist workbook, they go through it together. There's nothing stopping you as a client from buying the therapist workbook, and you can read through it. That's great, but the therapist is going to have more skill and tools in knowing what that workbook is talking about and how to do it probably more easily than you will. And sometimes the therapist makes decisions about, this is not relevant, or this is really useful, or we need more time on this. You got to individualize these things. All in all, though, the specific kind of therapy doesn't seem to matter very much in terms of, does therapy work or not. And also, good to know, therapy seems to work as well or better than most medical therapies. So keep that in mind. We go see the doctor because we think what they do works. Sometimes it doesn't. And we go see our therapists, and what they do does seem to work at least or more effectively than medical therapies. All right. So what is important in therapy? What is important are these things: the therapeutic alliance. That means like the rapport that you have with your therapist, your alliance. Do you feel like you're working together on the same page, kind of marching in step kind of thing? There's something called non-specific factors. And non-specific factors are things like, do I feel listened to? Do I feel cared about? Is the therapist warm and supportive, or whatever, that sort of a thing. Those are non-specific factors. In other words, they're not specific to any particular kind of therapy. They're just specific to generally all therapies. So in all therapies, you kind of want to have this non-specific general sense of support in therapy. Then there are the specific factors, which would be the type of therapy, the amount of experience that the therapist has, etc. Those kinds of more specific factors. The actual therapist, who the therapist is, actually does make a difference. People don't want to believe this because we want to make everything into like, this is a standard treatment, like a pill. Just take this pill, everyone gets the same thing, and it's all better. Well, nobody gets the same thing across therapists. Therapists are different people. Incidentally, pills do different things to individuals too. And so you can't imagine that one pill is actually giving the same exact treatment to everybody. That's sort of an idea that we have, but we ignore lots of individual factors and the impact that those have on what the pill does to our body, much less an individual therapist. So the actual therapist does seem to make a difference. We'll talk a little bit more about that. So what doesn't seem to matter, and boy, do advanced like PhDs, so I have a PhD in clinical psychology, and lots of PhD psychologists really don't like the fact that the amount of training and the kind of degree and the years of experience and the therapeutic orientation don't seem to matter in terms of whether therapy works or not. You want to think, well, I did the hardest, best, whatever, and so of course I'm going to do better than, people with only 2 years experience or whatever. And that's not the case. It is not the case. So too bad, so sad, right? The amount of training doesn't matter. Your years of experience don't really seem to matter. The only thing that really matters is in terms of, are you getting better as a therapist? And that's something that is not really well taught or taught at all in graduate school. So I can tell you, in my graduate school, when we had supervision for therapy, most of our supervision came from outside of the school, because the people who were in the school were academics and they weren't really therapists. Some of them had a little bit of a practice, but we didn't get a lot of value in terms of their therapy experience. The value from therapy experience that we got came from people in the community who were doing therapy, who supervised us. And so they're the ones who trained us to do therapy. In school, we didn't learn a lot about how to do therapy. We had some classes, but I'll tell you, the classes, I don't even remember much of the content. I remember being in the field with the supervisor and working that way. That's how I learned to be a therapist. And then learning from then on, you can't ever stop and feel like once I've done graduate school, I'm done. I mean, it's sort of like once you've done graduate school, you're at the very beginning and you're just starting. You need mentorship, you need connections, you need to continue to learn and work on things. So amount of training, basically in terms of graduate school or years, doesn't seem to matter. The client age, the client gender, the match of the gender of the therapist and the client, whatever disorder it is or diagnosis, these don't seem to have effect on therapy success either. There's over 400 different types of therapy today. Only 145 have evidence basis for them. This is, again, in large part because some therapies you just can't study. You can't put them into a scientifically run randomized controlled trial because they don't meet the parameters of what that looks like. They're too individualized. And so you don't have nearly as many therapies that have evidence behind them as you have therapies that are offered. But there are a lot of therapies that seem to be successful based on outcome. Therapists have blind spots. Again, this is data that therapists don't like, and I think it's hilarious. So 90% of therapists think they're better than their colleagues, like they're in the top 25%. 90% think that they are in the top 25%. You've got to be laughing. I mean, it's just funny. A little bit of a blind spot. Even worse, the worst therapists, like the bottom 25% of all therapists, think that they're average. They think they're just like their colleagues. So both of those things kind of crack me up because it seems that, like in many, many areas, therapists have a blind spot in terms of how good they are. Now, of course, I'm in the top, 25%, right? Like we all think that as therapists, we all are sure. 90% of us are sure that we are better than our colleagues. It's just so funny. Of the people who do therapy, 8% actually deteriorate in therapy. For a number of reasons. Some reasons might be the therapist. It might be a poor fit. Some things might be that the client is working on things that they can't work on with that therapist, or they're getting poor advice. Sometimes it's about client value. There's a whole lot of reasons why people might deteriorate in therapy, but we do know that kids seem to deteriorate at twice the rate of adults in therapy. So you want to think about that. Make sure that the match you have with the kid is really good. Sometimes you get really judgmental therapists who want to parent the child instead of be a therapist. And sometimes that can be a problem. And sometimes the parents are sort of like allied with the therapist. and they're both working together to make the kid do certain things. And then, of course, that doesn't work very well. All right, here are a couple studies on this idea of therapists having a blind spot, which again, you can see I'm so amused by. So the Hatfield study, this was a study of mental health measurements versus therapy notes. And so they're giving people questionnaires that were, reliable and valid questionnaires about their mental health. And then they're looking at the notes in therapy to see what the therapist saw. And what that showed was that 75% of the people who were getting worse, as measured by those questionnaires, were totally missed by the therapist. The therapist did not have a clue that they were getting worse, right? So in the therapist notes, they did not catch 75% of the people who were getting worse. That's a problem, right? That's a blind spot. Another study. This study was of 20 clinicians and 20 trainees. So people that the clinicians maybe were supervising or that were just in training to do therapy. So out of 40 cases that were getting worse, so they had 350 cases. There was a total of 40 out of those 350 that were getting worse. The clinicians identified 0 of those. And of the trainees, 1 trainee identified 1 case that was getting worse. And so what we're seeing here is that it's really easy for therapists to miss it when the client is not getting better, when in fact they are getting worse. So it doesn't happen very frequently that clients are getting worse. But when it does, frequently that therapist has a blind spot. And so you want to think about adding into therapy some way of consistently checking to make sure things are okay, and to make sure that the client is not getting worse without you knowing it as the therapist. And remember, even despite all this, we still have the data that show that therapy has better outcomes than medical treatment. All right. You have this thing called super shrinks. So I worked with a guy ages ago when I was an undergrad at BYU, who was really amazing in terms of doing research on therapy outcomes. He was awesome. He was well known. He was such a good mentor. And he started doing this thing where he looked at what he called super shrinks, like the therapists who seem to get everybody better faster. So the kind of therapist that I guess 90% of therapists think they are, right? And so what he found was that super shrinks had clients that got better 50% faster and dropped out 50% less than other regular therapists. And so we looked into this. And other people have looked into this too. And so this sort of idea, it's not just him. Other people have looked into this as well. What they find is that super shrinks, what makes the difference is that they ask for feedback and they hear that feedback. Like you can ask for feedback and then you can just sort of ignore what the person says and just hear it in your own ears, like, oh, they're saying things are great when they're really not saying that. Everybody has watched somebody not hear what was actually being said to them, right? And another thing that super shrinks do is they work harder to improve. And so they are doing a lot more work on their own to become a better therapist than the average therapist would be. They spend a lot of time pushing past boundaries of proficiency. Like, it's not like, okay, well, I'm good enough and that's enough for me. They want to excel. And so they push. They're constantly striving to excel. And that's part of what makes up a super shrink. And so there's this guy named Anders Ericsson who was the expert on experts. That's sort of his specialty. He wanted to understand what makes experts expert. And so he became the experts on experts. And he came up with some ideas, one of which is that lack of talent is irrelevant to great success. So he's been examining people that are expert in a lot of areas. And just by the fact of, are they an expert or not? It doesn't matter what the area is that he's looking at. And what he finds, it's not about talent. Natural talent or lack of natural talent is irrelevant to success. Well, isn't this hopeful for every single person? It's fabulous news. It's all about work. That means anybody can do it. Anybody. If you are just willing to put in the sweat, blood, and tears to get better, that's what you need. Sweat, blood, and tears. That's the secret. It's not natural talent. And so the playing field starts out pretty even. The thing that makes the difference is that there are lots of people who are just not interested in putting in the work. And so they end up with mediocrity. You might fool some people some of the time, but overall, mediocrity is what you're going to, which is the definition of mediocrity, sort of run of the mill, average, nothing excelling. So excelling doesn't come because of things like heredity or giftedness or talent, any of those things. Excelling comes out of really working hard. The example that Anders Ericsson gave that I thought was really useful was the example of Michael Jordan. He was cut from his high school basketball team. He was cut. And so you would think, well, it's Michael Jordan. How could he be cut? That's not possible. This man worked. He didn't just have talent drop on him from the sky. He worked really, really hard. And this is a principle that I try to teach all the time in my life, is that things don't drop on you out of the sky. And when you look at others and you think that their success came easier to them than it would to you, that is absolutely untrue. I had a meeting once with a lot of people who were involved in selling a particular product, and they wanted to improve. So I would come give them talks on business models and self-improvement, and that's fun. It was super fun stuff. And so this one time I had all the really successful people stand up. And then I asked the other people, why are they successful? What do you think? And they like out loud said things like, well, she already had all these contacts, and so it was easy for her to use those. Or, I think she just has that personality that makes it easier for her to be with people. Or, there's all kinds of ways that they listed reasons that basically said the people who are successful had an easier time than I'm having. And then I had the people who are successful talk about their journey. And it just blew that reasoning away. Absolutely. We had somebody who's doing extraordinarily well, who only had a high school degree and who was in a horrible accident and who had ended up addicted to pain medication and had, really difficult time with family in the top. Why? It didn't drop on this person. It was work. Hard work. There's another person who was homeless for a while and who just lived out of their car. And again, work, super hard work. Things don't drop out of the sky. Things happen because you work hard. And so if you're still under this illusion or delusion that some people have it easier than others, it may be protecting your own self to think that you're working harder than they are when you work. You're maybe just protecting your own ego, because it's really about how much do you want it? Are you willing to work that hard? So super shrinks wanted it. All right, so now we're going to talk about DBT. DBT is a kind of therapy that I do. DBT stands for dialectical behavior therapy. It's not the only kind of therapy I do, but I do DBT with pretty much everyone I see, even if it's not officially exactly DBT. It's still informed by my experience with DBT and my appreciation for what it offers. I like DBT because it's very comprehensive, it's complicated. You can use it to explain all kinds of things, and you can use it to help all kinds of things. Originally, DBT was designed for suicidal people or people with borderline personality disorder. Now it is used across the board for lots and lots and lots of things. Parasuicide was a part of what it was built to stop. Parasuicidal behaviors are behaviors that are like suicide, but not suicide. And so like threatening to suicide a lot, or kind of making suicidal gestures without any intention of actually dying. So we call that parasuicide. And as you can imagine, therapists would burn out a lot. These are really difficult clients to see. And so DBT was created to figure out what would work with these people. And so the idea overall, like one of the big foundational DBT ideas is do what works, do what creates outcomes, get those results. And whatever you need to do to create results, that is the therapy. And so it's very, very pragmatic, very American in that way. There are 4 different components to DBT. There's individual therapy. Individual therapy is like the center. It is the wheel that everything else turns around. Individual therapy is the thing. And so the individual therapist is seen as in charge of the person's whole treatment. This runs into a little bit of trouble sometimes when you're in some sort of a team approach where the psychiatrist is used to being the one who's always in charge and who makes all the decisions. It's kind of, psychiatrists don't always love that the DBT model is that the individual therapist is in charge of the treatment. But that's pretty much what it is, and that is the most important thing that a person does. Now, DBT has gotten used and modified and recreated and scattered and diluted and intensified all over the place. And there are lots of people who say they do DBT who don't stick to the model. And there are people who think that they're doing DBT when they're only doing part of what makes up DBT. And so a lot of times you'll have people that will run skill groups. And they'll say, oh, you need to go to this DBT therapy. And they put the person into a group therapy. And they say, well, that's DBT. And group therapy is not just the only thing in DBT. So in the group, they learn specific skills. So the individual therapy is where the person applies the skills. The group therapy is where they go to learn the skills. You can't say that learning the skills is DBT because all you've done is learn the skills. The hardest part is applying the skills, actually doing the skills. Learning the skills is pretty easy. Applying them, that is where the rubber hits the road. And that's where my favorite Italian proverb comes up again. Between thinking and doing is an ocean. Between thinking and doing is an ocean. And it is an ocean full of teaching people how to swim. I can't swim for you, but I can sit next to you and teach you how to swim. I can encourage you. I can shout suggestions over at you. I can, cheerlead and all that stuff. I can't swim for you. I'm teaching you how to swim. You and I are working together to apply those skills that you learned in the group. It also includes individualized phone coaching. Reason being because sometimes you can't figure out what to do in a moment of crisis and you need help right then. And that makes an incredible amount of sense. And so I'm open to people texting or calling. Most people don't call anymore, they text. And they will say, help, I need blah, blah, blah. And so they need things just right in that moment. And then if I can help them, I am happy to help them. And so individualized phone coaching is a very successful part of DBT. And you would think that people would take advantage of it. And almost nobody takes advantage of it. And I've had very few conversations about stopping or slowing down calling me or, try this first before you call me. I've had almost none of those conversations. Most of the conversations I have are, you are not using this enough. You need to call me faster. You need to ask for help right away. That's what most of the conversations are. And then the fourth part of DBT is a therapist consultation meeting. This is a meeting just for therapists. So if you remember, this kind of therapy is with people that are really struggling. It's hard on therapists and they burn out unless they get support. And so the therapist consultation meeting really does 2 things. First of all, it offers a lot of support for therapists, just like this kind of camaraderie. Yeah, we're all in this together. How can we help you? How can we offer ideas? How can we help you see what other things you might do? And then the other component is making sure we're all still staying in the same place. that we're in the world of DBT and we're going to stay in the world of DBT. We're not going to go off and like do primal scream therapy and call it DBT. So we're just making sure that we're sticking with the model. That's another part of therapist consultation. DBT assumptions are that people are doing the best they can. I love that assumption. It's so comforting to me to be able to stand by these assumptions and offer them to people who are coming into my door and suffering. And for me to say, you know, I'm making an assumption, and it's not just like, yeah, you probably, you know, you really, really genuinely mean this. You genuinely mean, I know you're doing the best you can. I know you are. And at the same time, I know you want to improve. And at the same time, you have to learn new behaviors in therapy and in the context of your day-to-day life. So you're doing the best you can, and you have to do better, because right now, clearly you're suffering. And so both of those things are obviously true. So I'm going to add some things with you to help you do better. And so there have to be things that you agree to go and do, that you're probably blind to, or maybe you feel like you're not encouraged enough, or maybe there's something about you that's really willful. You know, a lot of times people run into this willfulness where they're like, I know what I need to do, and I'm refusing to do it. You know, I'm just going to like refuse and just be willful. And then they're miserable. They're miserable. And so we talk about things like that in therapy, being willful, being willing. That's definitely a DBT concept. It's one of my favorite ones. And it's tough. You know, I've spent a number of therapist consultation meetings where we start off with a mindfulness exercise. And one of my favorites is, think about how you've been willful today. It's fantastic, because we realize everyone does this willfulness thing. The last assumption, not the last assumption, the last one on this page, people cannot fail in DBT. A lot of times people will come to therapy and then they feel like they failed, where we'll say, no, the treatment failed you. The treatment failed you somehow. And that's the assumption we make. People cannot fail. I love this one too. People may not have caused all their problems, but they have to solve them anyway. That's such a comfort. A lot of times people feel like, well, I shouldn't have to solve that because it wasn't my fault. That's a big thing. People want to stay victims. Like, I didn't make this happen, and so I shouldn't have to solve it. You know, like the universe should solve it for me, or, you know, ice cream sundaes should drop from the sky for me because I deserve this. Well, I mean, probably ice cream sundaes could drop from the sky for all of us because we probably all deserve that. People have not caused all their problems. That is true, but they still have to solve them, even though they haven't caused them. Really getting that is so freeing for patients when they really get that, even though I haven't made this problem, I still am responsible to solve it. It's awesome. People do need to do better, try harder, and be more motivated to change. That's an assumption we make. It goes hand in hand with you're doing the best you can and you need to do better. Both of those things are true at the same time. And the lives of people who are suicidal are really miserable and unbearable as they're currently being lived, and solutions happen. It does get better. It so gets better. Once people figure out a couple things, they have said over and over and over, I can't even tell you how many clients would say to me, you know, last year I was really thinking about ending it all. And I would think, yeah, I know, I was with you. I get it. Yeah, I was there. I remember talking to you. I remember us talking about this. And then they're always so glad that they didn't. They're so grateful for that new perspective. And it just feels like their lives feel so different. And they'll say, I don't even know who that person was. Like, I can't even imagine who that was. The most caring thing a therapist or a treatment provider can do is help people change in the ways that bring them closer to their ultimate goals. So it's not the therapist's goals, it's the other person. It's the person in therapy. It's your goals. Clarity, precision, compassion. Those are utmost important, utmost. And this treatment relationship is a collegial, equal relationship. It's not at all one where the therapist is like, oh, I am the therapist and you're the patient, so I'm up and you're down. It's not like that at all. We see ourselves as consultants, not as a vertical relationship, a horizontal relationship. We are equals, we are consultants. I'm here to help you. I'm not the expert on your life. Principles of behavior are universal. So behavioral principles exist. You know, when you're positively reinforced for something, what I said was, when you're positively reinforced for something, you're going to want to keep doing it. That's going to affect me and you. So if a client comes in and they are really punitive, pretty soon I'm going to stop wanting to see them. That's just a principle of behaviorism that is going to be true whether or not I'm the therapist or the client. And so treatment providers also need support. Treatment providers can fail. The clients don't fail. Okay, we teach different skill modules, generally 4, except for if you have a teenager. So the 4 are mindfulness, interpersonal effectiveness. In other words, how can I get what I need from other people and keep them from not liking me? So what I'm saying is, how can I get what I need and keep people liking me? And keep people liking me. How can I regulate my emotions so that I'm not acting all the way out of reacting to my emotions, but choosing what I do instead of just trying to get rid of my emotions. Distress tolerance. How can I manage this distress and not make it worse? Okay. And then for teens, we talk about middle path, which is really looking at what are the extremes and then looking what is the balance and what makes more sense for you. Okay, finally, we run into what we call dialectical dilemmas. Dialectical dilemmas are a part of DBT, understanding what goes on in most DBT patients. So you have a number of dialectical dilemmas, and I'll tell you about them. One of them is this idea of emotional vulnerability plus self-invalidation. So on the one hand, you're vulnerable. On the other hand, you're telling yourself you're no good, you're not enough, you don't actually feel that. That's just silly. This feeling is just made up. It's not real. So you can see there's a dilemma between those two extremes. So what we know, though, is that if you're always reacting, even to small events, and you're discounting your emotions, like, ouch, that really hurt my feelings, but my feelings shouldn't be hurt, but it really hurt my feelings, but they shouldn't be hurt. What do you think? Right? The combination of that leads to making your problems seem really more simple than they are. And shame and a lot of self-criticism. And so it doesn't work. So we kind of work with people to help them through that dilemma. Another one is passivity, active passivity, which seems kind of weird, but when people are actively passive, what they're doing is they're helpless about all of their life problems. They just sort of give up, like, well, I can't help it. And then they just go and can't help it. So they go with what they want to do or what their impulse says, with this belief that they can't help it. Active passivity. And so when they're really stressed out, they sort of demand the environment or the other people in the environment solve their own problems. They don't learn how to solve their own problems. So then when they don't learn how to solve their own problems, they don't feel confident in their ability to solve their problems. They don't have a sense of self-efficacy that they can solve their problems. They don't have the experience of having solved their own problems. But trust me, everybody can learn how to solve their own problems. When you learn how to solve your own problems instead of making your environment solve it for you, which usually not the best plan, then you get a sense of accomplishment and deep happiness you can't get any other way. It's kind of awesome. A lot of times people with borderline personality disorder, for example, are really appropriately assertive. And so you get fooled into thinking, oh, well, they're fine. Look, they could do it in that situation. Why can't they do it over here in this other situation? And so what gets missed is that you have apparent competence that is not across the board. It is inconsistent. It depends on circumstances. And so you have to shore up all the other ways in which the person's competence is missing. And so we're balancing this. They kind of look competent, but at the same time, they're being totally passive. All right, and then the last one is unrelenting crises versus inhibited grieving. And so if you have crisis after crisis, it's like, you may have met somebody who has this, it's like it's always a crisis. How are you today? Next crisis. Every single day, every single week, it's another crisis. And at the same time, they never allow themselves to recover. They never really allow themselves to have their feelings, to have their grief. And so that constant crisis leads to a lot of pain, a lot of traumatically painful emotions. And then the person's trying to avoid all those emotions, which means therefore they're not listening to the ways in which they have to change their life. And so that can be a problem too. Now, to end, I'm just going to show you a couple worksheets from DBT. There are hundreds of worksheets available. The amount of resources for people who are doing DBT is really amazing. And so you have worksheets that teach principles, worksheets that demonstrate principles, worksheets that you fill out. They're like literal homework where you're writing in, okay, on Monday, this is what I did, on Tuesday. Or you're saying, okay, I'm going to break down this whole communication that I had with my boyfriend or something. And here's what happened, and you're breaking it down on paper. There are lots of worksheets that really help. You can do those in individual therapy. You can do them in the skills group. They're appropriate both ways. So there's one of them about states of mind. Here's another one on doing distress tolerance. This is another just kind of informational idea about forgiveness. So to end, in therapy, the questions that you want to ask are, do you think the person can help you? Do you get a sense that this person knows what they're talking about and they can help me? Do you like the therapist? That's important. If you go see someone and you're dropping money into this person and you really don't like them, just find another therapist. You got to like the person to do therapy. Do you feel like the therapist cares about you? That's important. You should feel like they care, right? And do you see progress? Of course, not after one session, really. But you should see progress within a reasonable amount of time. And if you don't see any progress, then you have to have that conversation with your therapist that, I'm not seeing progress. It's like I'm coming to meet with you and we're talking about, well, so what happened this week? Well, I had ice cream, we're talking about my week. Nothing's happening. I need to create change in my life instead of just have somebody to share ice cream stories with, right? And so one of the things I tell my clients is, you'll know when you're done with therapy because you'll get bored and suddenly there won't be very much to talk about. And it seems like it's impossible. When you're in the middle of therapy, you're like, I can't even imagine not needing to go see my therapist. But once you're pretty much done, you're like, talking about soup recipes. And it gets really clear really quick that you're ready to move on. I know it. I can see it coming in my clients. I could go home and say, all right, well, I know this one is going to be ready to leave therapy within, easily within a month or within a couple weeks. Or I think we've had like our second to last session. I think next time this person's going to come in and say, I'm ready to be done. Sometimes I bring it up, sometimes I don't. It really depends on that particular person and what's going on with them. So you have to see progress. Finally, you do get what you pay for in most circumstances. Most circumstances, you get what you pay for. You want to think about what are you getting with this therapist's level of competence. You can't assume that one therapist equals another therapist equals another therapist. There is a lot of differences individually. As you've seen, it's not about, well, as long as I get a PhD, then she'll be or he'll be good. It's not about, well, they've done a DBT program, therefore they're good. I've met a lot of DBT therapists I would never send a client to, ever. And I've seen a lot of therapists with, lower level training that I think are fantastic. So it's really variable. So what you have to do is figure out who works for you and then see that person. All right, this is the end. It's the end of your class lectures. Today was the last one. Oh my goodness. So exam 4 this weekend, due by Saturday, May 9th at midnight. Don't forget to take your exam. Your final project, there's information. I sent you an announcement. The information on that is in the assignment. It's due Tuesday, May 12th at midnight. Don't forget the quiz and activity for this chapter. And to close, okay, I said I was going to do this. I am so happy. So happy I got to be your teacher. Thank you. And I know this whole COVID thing was nuts, and this whole shutdown thing was a little crazy. I think we've hung in there, and what a great ride it was. So thank you. Thanks for the privilege of being your teacher. All right. Take care.